Well, good morning, everyone. That was an enlightening talk. I have to rethink how I eat. But I'm on track doing most of the right things, at least I think. This was really very helpful presentation. I really enjoyed this. So let's talk about something else. Let's talk about remission. And I'm targeted to talk about the facts and what is possible. So we'll see whether I'll deliver on that part of the presentation. But what I'm going to talk about, disclosures are seen here. The main disclosure for this presentation is that the concepts of remission that I'm going to talk about apply to all forms of vasculitis, in that they are chronic illnesses for which we currently, unfortunately, don't have a cure yet. But some of the specifics I'm getting into pertain mostly to GPA and MPA. So what does remission mean? That is a question that comes up in the office all the time. How do I know whether I'm in remission? So this really raises the question, what does remission mean to patients? And what does remission mean to us as physicians? And we really need to have some clarity on this so that we're essentially able to talk together meaningfully about our goals. What is the joint goal? Where do you want to be? And how can we help you to get there? And in order to do this, we have to have a little bit of a more extended conversation about remission, because as you will see, remission can be a lot of different things. And unless we really nail down what we're talking about in the context of a treatment plan, we can get on to divergent path very quickly or get confused. So why don't we start with the definition of remission? And when we as physicians don't know what we're doing, we go to Dr. Google and ask. So the first thing that comes up is the Merriam-Webster, and I can tell you that definition of remission wasn't really very helpful for this conversation. But then the second or third link were more helpful. The second link gets us to Wikipedia, which has a great source of information for many things. And they define remission as either the reduction or the disappearance of the signs and symptoms of a disease. The term may also be used to prefer the period during which this diminution occurs. A remission may be considered a partial remission or a complete remission. So that's rather a complex definition, isn't it? MedicineNet makes it a little bit more easy, or easier, I should say, and it's similar. Remission is the disappearance of the signs and symptoms of cancer or other disease. A remission can be temporary or permanent. So what's in this? First of all, what's in this is that we in the vasculitis community borrowed the term remission from the oncology world, from the cancer world. But what it really says is remission in and of itself as a standalone term is not very helpful, because there are plenty of qualifiers that go with the term remission. And these qualifiers can pertain to the duration of remission, for how long is a remission present, or it can pertain to the degree of remission. Is it complete? Is the disease currently not detectable in your body? Or is it partial? Has the disease shrunk or been pushed into the background? So how these qualifiers are used is very important in the conversation that you need to have with your healthcare providers. The general implications when we talk about remission go a little bit further. They clearly say the disease is chronic and we currently do not have a cure yet. And what that means also is that the disease can act up again. It can come back. It can cause trouble again, meaning you can have a relapse. And it also implies that we as a team need to do something together in order to maintain that state of remission for as long as possible, and ideally forever. So with that, we go back to what does remission mean? Well, it first of all requires that we survive the acute disease. And I think overall, the vasculitis community has come a long way over the course of the last 30 years, to a large extent as a result of the efforts of this organization. So to really improve medical care and early recognition, and the fact that we actually have much, much better survival now for patients to offer than about 50 years ago. So remission ultimately is the goal of treatment once we have the acute inflammation under control. And remission really requires significant immunosuppression to induce it, but once it's induced, we generally can back off on the heavy immunosuppression and replace it with a less heavy immunosuppression to maintain the remission. And sometimes we can get off the immunosuppression altogether, but we then need to put in a safety net or a surveillance system that allows us to detect changes that indicate a relapse in the future, so that we can detect a relapse as early as possible before it causes more damage. So what does remission mean to physicians? It may not be always the same as it means to you, and therefore you need to have a conversation with your physicians in the office about what each of you mean. When we as physicians talk about remission, what's in our head is there is no evidence that we can detect with our current tools at hand, no evidence for disease activity or inflammatory activity that's caused by the underlying disease. Inflammatory activity can be caused by a complication of the treatment, like an infection, but it really means absence of active inflammation caused by the underlying disease. Now, remission, unfortunately, doesn't mean necessarily absence of symptoms, and you know that better than anyone. And it also doesn't mean that you're feeling normal. We heard this fantastic presentation from Dr. Amodio on Friday night. You know, there is the old you and the new you, before diagnosis and after diagnosis. And there needs to be clarity what these differences are and how we can best deal with them. But the ultimate goal should always be to make you feel normal as much as possible again. But when we talk about remission, it is very important to know that we're not necessarily expect that you feel normal in order to declare you to be in remission. So damage causes symptoms, you know that very well, so the primary goal of any treatment, including remission maintenance, is to minimize the damage or the worsening of damage over time, because the ultimate goal is to feel normal, although that is an aspirational goal for many of you, as you know. So when we talk about clinical trials and clinical trial results in the scientific community, we also use the term remission in many different ways, and this is really where the devil is in the detail. When we compare trial results to talk about how good is one drug to put a patient into remission versus another drug to put the patient into remission, we really need to look at the fine print of each of these trials to see how did the primary outcome or the secondary outcome of the trial get defined, and how is it comparable from one trial to another. This is data from the RAVE trial, where we looked at various different endpoints, and depending on how you use the term remission in context of a definition, you get completely different results. So definition defined as no detectable inflammatory activity due to the disease, which we measure on a scoring system, the Birmingham Vasculitis Activity Score, or BVAS, that comes in various different permutations. So if the BVAS is 0, that means that we as physicians cannot detect any inflammatory activity. So BVAS of 0 achieved at any time in the trial was in the order of 90%. And that was only 90% because some patients, due to safety measures put into the trial, did not continue the trial after the first 4 weeks, and they were counted as failures. So that doesn't mean that they all did badly, but the definition of achieving a remission during the trial at any time with a BVAS of 0 was 90%. If you say, well, that can be on drugs, of course. It can be still on the remission induction drugs. It can still be on various doses of prednisone. So a remission of 0 activity with how much prednisone, that is yet another question. So if the definition includes a specific dose of prednisone, like less than 10 milligrams of prednisone, or less than 4 milligrams in the MIRA trial for EGPA, you get different numbers. So if you allow a little bit of prednisone, then more than 80% of patients will achieve that goal, or did achieve that goal in the RAVE trial. And if you insist on no prednisone at any time in the trial being part of the definition, then only north of 70% of patients achieved that goal. So really, even in the scientific community, we need to be very much aware of what we're talking about when we compare endpoints. So what are the keys to better outcome? This has been talked about in various permutations at this meeting. Of course, key to good outcomes is early diagnosis. The quicker we can implement remission induction treatment, the less likelihood of a bad outcome we have, the less likelihood of damage we have. And for that, we fortunately have effective drugs. We're now searching for effective drugs with a better side effect profile. Equally important for the overall outcomes we've learned over the years is to really maintain renal function, because the renal function at 6 months is probably the single best predictor of overall survival of patients with ANCA-associated vasculitis. And then, of course, we need to prevent serious infections, and that means less glucocorticoids and appropriate prophylaxis against infections. Once we have induced remission, then we really need to maintain it. And why do we need to maintain it? Well, again, ideally to have you feel normal for as long as possible. That's the aspirational goal. But in order to achieve that, what we really need to do is minimize damage, meaning minimize irreversible loss of organ function. And how do we do this? It's a balancing act. And this balancing act weighs the risk of a relapse versus the risk that comes with ongoing preventive therapy, which may or may not be unnecessary. The risk of a relapse comes with more risk of damage, both from the disease with the relapse as well as from the high-dose steroids that to this day we still need to use to put the relapse back into remission. And we have to weigh that against the ongoing treatment with immunosuppressive agents and their long-term use toxicities. And we reevaluate this every so often as the medicines that we have to keep patients in remission change over time, and we think are getting better. So how do we maintain remission? Really, remission maintenance needs to be individualized. And this is because we learned most of what we know about remission maintenance from clinical trials. And many of these clinical trials are actually remission induction trials. Some, and more frequently nowadays, trials are designed to measure adequate remission maintenance, but clinical trials are only going on for a limited period of time because we want to get results in a lifetime of an investigator. So for these reasons, most of the data we have either are coming from trials that were designed to follow patients for 18 months or 2 years, but rarely up to 3 years. Whereas your journey with the disease here in this room, probably for most patients, already way exceeds that period of time. So we have to really make more long-term plans for remission maintenance, and the data from trials can educate us only so far. Also, we need to keep in mind that data from trials really tell us something about groups of patients and not so much about individuals. Now, we try to extract as much data as possible from the clinical trial so that we get a hint for what actually happens to smaller groups of patients that are better defined and more easily comparable. But most of the trials are really not powered, meaning they don't have enough patients in them to really do statistically sound subset analyses. So really the question is, who needs maintenance, and how do we monitor you once we have achieved remission? How do we know that you stay in remission? And what do we do to monitor? And we really are looking for any sign of return of disease activity and for treatment side effects. And when you come to see one of us at Mayo for a follow-up visit, we generally try to have you do a battery of tests in the morning and then see us in the afternoon to discuss the results and see where we go from here. And this screening battery is really coming in the form of a six-pack. You know, I'm German, I like beer, and beer comes in six-packs, so it's easy to remember. But there are really 6 components to this battery of tests that actually do make some sense. So the first thing we look at is markers of inflammation, sedimentation rate, and C-reactive protein. Now, that goes up for any sign of any inflammation in your body, be it the disease or be it the complication of treatment. We do a complete blood count with the differential that tells us something about disease activity in some vasculitides, particularly EGPA, when the eosinophil count goes up, but it mostly tells us something about drug toxicities, which has a tendency to drive the white count down. We do a metabolic panel looking at your kidney function and your liver function. Again, disease activity, kidney disease, kidney function, stability of kidney function, as well as drug toxicity on the liver front. We look at the urine to see whether there's any sign of inflammation in the kidney showing up in the urine, particularly microscopic blood. We do a chest imaging study to see whether something is happening in your lungs that doesn't cause symptoms yet. And ultimately, and particularly in patients with PR3 ANCA, we monitor the ANCA level. And with all this, we get a picture that we can relate to the picture that you had at original presentation of the disease and subsequently when you went into remission. And over time, we get a good profile, and when we see any changes in this panel, we can draw some conclusions about what tests to do next to really get to the bottom of any potentially recurring problem, or to reassure you that you continue to be in stable remission. Now, we use various drugs for remission maintenance, and we've had quite some advances in that field. And I just want to briefly summarize this. In the past, when we used to induce remission mostly with prednisone and cyclophosphamide, we used remission maintenance drugs, either methotrexate or azathioprine or mycophenolate mofetil or Cellcept, and these drugs are pretty much in the same ballpark when it comes to efficacy of keeping patients in remission, and the choice of drug really depended on your individual situation. So for instance, if you had some residual renal insufficiency, we would not go near methotrexate because that could lead to toxicity very quickly. We would go to azathioprine instead. And there's different intolerances. Some people tolerate methotrexate very well and don't tolerate azathioprine at all, and vice versa. And sometimes patients don't tolerate either, and then we go to Cellcept. But the most recent advance has been coming with a study that was conducted in France, the Main-Ritzan study that has really shown that rituximab is actually much more effective for remission maintenance than azathioprine, and by proxy, probably methotrexate and Cellcept. So this has led to the FDA approving rituximab now for remission maintenance also, and particularly for PR3 ANCA positive patients who are at high risk for relapse, the rituximab maintenance becomes more and more the standard. So what are our opportunities to improve remission maintenance? It really is all about retreating in an individualized fashion in the long run. And in order to do that, we really need to develop a plan. And that requires that we listen to you, what your goals are, and we come to mutually devising a plan. And then you need to contact your physicians as soon as something changes. We have only so many biomarkers. Actually, we have very few biomarkers that help us predict a disease flare. But what you feel is actually a significant biomarker. There is the study that was done in conjunction of a clinical trial that was called the Wegener's granulomatosis etanercept trial, and that trial showed that patients feel the oncoming of a relapse usually before we as physicians can detect objective markers of the relapse. So the physician global assessment score, which you usually complete when you participate in a clinical trial every time you come for a study visit, went up significantly a visit before the actual flare was scored on the Birmingham Vasculitis Activity Score. So really, we as physicians have learned from this that you as patients are a pretty good biomarker. Now, the patients that are at highest risk for relapse are the patients with PR3 ANCA who are already having a second relapse and carry a diagnosis of GPA. And those are the patients where the survival goes down very rapidly. In contrast to newly diagnosed MPO ANCA patients with microscopic polyangiitis, they have a very low relapse rate. That doesn't mean that they don't relapse. You see that that line isn't completely flat on top there. It goes down over time also. And once an MPA ANCA patient has had a disease flare, they fall into a different risk category. So over time, we need to define a risk category for each individual patient and factor that into our decision making of how we want to prevent relapses going forward. So what about testing ANCA serially going forward? We again looked at this question in the context of the RAVE trial and were able to identify a few factors that actually affect quite significantly the clinical utility of serial ANCA testing. And we found out that the risk of relapse following a PR3 ANCA rise really depends on various factors. One is really not under anybody's control in this day and age. One is the assay methodology, and unfortunately in most places the assay methodology for ANCA testing that is available changes at the whims of the hospital administrator, as they may go for the cheapest offerings of the test, and as a result you may be tested with one assay in year 1 and another assay in year 2 or year 3, unless you're at a center where this is held fairly constantly. What also goes into the utility of ANCA testing going forward is your disease phenotype. And we found that it's most useful in the patients who present with disease manifestations caused by capillaritis or the small vessel vasculitis rather than the granulomatous disease features. So it's the crash and burn type of patients that in whom the following with PR3 ANCA is most useful. And it is most useful after rituximab therapy compared to other immunosuppressive therapies. And the reason for that is undoubtedly that after rituximab therapy, the ANCA level has a tendency to go down much more significantly or turn negative at a much higher frequency than after cyclophosphamide therapy followed with azathioprine. And as a result, a recurrence of an ANCA after it was negative after rituximab therapy is a much better signal of the immune system acting up again than when there is only wobble over a certain level, but the PR3 ANCA never went away completely. So rituximab as used for maintenance comes really in two ways in this day and age. There are two schools of thought. One is to really retreat every 6 months or every 4 months with a fixed dose like clockwork, essentially for prolonged periods of time. That is very effective. It depletes the B cells continuously, and for as long as the B cells are gone, you are very likely to stay in complete remission. But the question is, do you need that continuously, or is this potentially associated with a risk? And the biggest risk that we worry about, we don't have solid data yet. We may get these data from the retazaram trial. The biggest worry is that the continuous B-cell depletion may ultimately lead to a drop in your immunoglobulin G level. And the immunoglobulin G are the natural antibodies that your immune system makes to fight off infections. And when these IgG levels drop because the B cells and the B cells that ultimately are responsible for continuously making immunoglobulins, when they drift down, we ultimately lose the IgG, and you are at risk for infections if the IgG drops below a certain level. And if we can avoid that, I think then we make maintenance therapy even safer. So the second school of using rituximab for maintenance really factors in patients' individual relapse history and their individual data on B-cell recurrence and ANCA level increases, because every patient is their own reference point, and over time you can anticipate what the patient's immune system is doing after each rituximab infusion, and then you can individually time the retreatment based on recurrence of B cells or ANCA levels. And that way you can extend the intervals of rituximab retreatments quite substantially in many patients. And the French actually compared these two approaches again in a randomized controlled trial, and they found that they had the same efficacy of maintaining remission, but they got by with a much lower rituximab retreatment frequency. So the last word on how best to maintain maintenance with rituximab is still out, and there will be new information coming out shortly. So let me summarize. What have we learned? There are clearly different patients that have different relapse risk. In a nutshell, the relapse risk is higher in PR3-ANCA patients than in MPO-ANCA associated disease, patients with MPO-ANCA disease. The individual need to prevent the next relapse really varies from patient to patient. We are much more aggressive in maintaining maintenance with medicines, even at the risk of potential toxicities of the medicine in someone who sits on the verge of going on dialysis. So if you end up with a creatinine of 3 or an eGFR of 30 after your initial disease, the next renal relapse is unlikely gonna have you end up on dialysis, and we want to avoid that at all possible. However, if you have a normal renal function, there is a much bigger margin of safety. So if you had a renal relapse but start out with a normal renal function, if we detect it early, we can get you back into remission without too much loss of renal function. So we probably need a little bit less aggressive immunosuppression at all times, and we can rely more on monitoring in capturing a relapse early. We know something about the efficacy of different drugs. We know that azathioprine, methotrexate, and mycophenolate mofetil are probably in the same ballpark of efficacy, but rituximab seems to be better. Patients definitely need to be monitored during remission to assure the stability of the remission, as well as to look out for any potential toxicities of the medications, and in order to allow us to prevent them. And the specific maintenance and monitoring regimen really needs to be determined individually between each patient and their vasculitis quarterback. And I'd like to close with really thanking everyone who has contributed to making it possible to where we are today. Thank everyone for supporting the research, and the advances that make better care possible. That's my colleagues and research collaborators, the funding agencies, NIH corresponding, the industry, the Vasculitis Foundation, all the personnel at the sites that conduct clinical trials, including the study coordinators and nurses, and foremostly you, the patients, and your supportive friends and family and loved ones who really make clinical trials possible. Without you, we could not have done any research that moves the field forward. And believe us, we really realize that your participation in clinical trials does take some sacrifice from you, because you have to travel probably more often to a site. There's always a little uncertainty associated with any clinical trial, because if we knew everything, we didn't need to do the trial. So thank you for participating in research, for participating in the Vasculitis Foundation's efforts, and moving the whole field forward for the next patients who will be diagnosed tomorrow. Thank you.